Hi, everyone. Welcome. We are going to give it just maybe 30 seconds or so to let people join, and then we will go ahead and get started. Thank you for being here. All right. Looks like folks are still coming in. We'll give it just another 10, 15 seconds and we'll get started. Okay, looks like it's slowing down. So let's go ahead and jump in. Thank you so much for being here today. I'm Megan Seawald, manager of the Data and Design Core at the Eisenberg Family Depression Center. We are so excited to welcome you to the first session of our new webinar series, Secondary Data Deep Dives, High Impact Options for Mental Health Research. Today's session is focused on the Adolescent Brain Cognitive Development, or ABCD study, and we are delighted to welcome Dr. Terri Voepel-Lewis, professor of nursing and research professor of anesthesiology, who has worked closely with these data and very excited that she'll be able to share her experience with you all today. I also have my Data and Design Core colleagues on the call, Sarah Stoddard, Associate Professor of Nursing, Brianna Mezek, Professor of Epidemiology, and Emily Urban-Wojcik. So you may see them also weighing in the chat or helping to answer questions. Before we get started, I want to just review a couple of Zoom logistics. So this is a Zoom webinar, meaning that you'll be on mute and off of video for the entire session. So feel free to make yourself comfortable. Whatever you need to do during the session, we won't be able to see or hear you. Closed captioning can be enabled at the bottom of your Zoom screen if you desire. We will try to save about 10 minutes or so at the end of the session for questions and discussion, so please feel free to submit questions throughout the session using the chat box or the Q&A, and we'll answer those at the end. And finally, the session is being recorded today, so don't worry too much about taking notes. We will send the recording and the slides and a couple of additional resources out as a follow-up email in the next couple of days. If you're joining one of our sessions for the first time and are not familiar with the work of the Eisenberg Family Depression Center, this is just a brief bit of context about our work. So the mission of the center is to improve lives and empower communities through bold innovations and interdisciplinary collaborations across research and outreach that advance how we understand, treat, and prevent depressive illnesses. And within that larger mission, the goals of our program, the Data and Design Core, are to reduce barriers to academic research so that investigators can generate impactful, innovative research more efficiently, and to support emerging scholars so that they can build robust, long-term research careers in the field of mental health. And the key mechanism that we use to achieve those goals is secondary existing data. And we operationalize that goal through programs, educational sessions such as this, resource development, and more. And I'll say more about how you can work with our team at the end of today's talk. So today's agenda, this series is meant to be a deeper dive into specific data sets and to provide specific use cases so that you can better understand their application. We hope that you'll walk away with an understanding of both ways that you with an understanding of why you should use this data set in your research and how you can get started. So today we'll cover an overview of the data set, including what the goals of the study are, what's included in the data set, data access procedures, and then Terri will walk through an example of how she and her team have used this data set in practice. And through that, you should come to understand some of the strengths and challenges of working with this data set. Since this series is meant to be a deeper dive into specific data sets, we won't spend too much time talking about secondary data in general. But if you're new to working with secondary data, I would highly recommend watching our seminar series from last year, which was called Building a Research Career Using Secondary Data. This was a three-part series that walked you through how to use secondary data at each part of the research lifecycle. So getting started, strategies for grant writing, and advanced analytic approaches. Those recordings are available to watch on YouTube, and I will send out the link to those as a follow-up. So now to get into talking about the ABCD dataset, I'll start with a little overview before I pass it on to Terri. So the ABCD dataset is the largest study of child health, behavior, and brain development in the country. It initially started to examine the impact of substance use during adolescence, but has since greatly expanded. The goal of the study is to understand how biological and environmental factors shape brain development, cognitive function, and mental health during adolescence. So it's really focused on development and what factors shape change over time. And it uses a longitudinal cohort model to do that. There are just shy of 12,000 participants who were between the ages of 9 to 10 years old at enrollment and enrolled in the study over a 10-year period. This is a national study that's coordinated and funded by the NIH and recruits from 21 academic sites across the country, including right here in U of M's psychiatry department. Data collection began in 2017 and became public in 2018 and has resulted in over 1,000 publications with many hundreds of papers focused on mental health specifically. ABCD includes a lot of different measures across 7 main domains, which you can see listed here. Physical health, which captures things like exercise and physical activity, medical history, healthcare utilization, medication use, sleep, and more. Mental health, which includes diagnoses, measures of impulsivity, inhibition and reward-seeking behaviors, resilience, adaptive functioning, and psychopathology. Substance use, which includes use, intention to use, and consequences of use. Neurocognition, which includes vocabulary, attention, and cognitive control, executive function, working memory, and more. Cultural environment, which includes things like parental supervision, family dynamics, and religion. And those last 5 domains are all self-report survey data, which are collected on an annual basis. And then the data set also includes brain imaging and biospecimen data, including drug screens, hair, blood, and saliva samples, and DNA samples, which are collected every other year. It also includes some optional elements like school and teacher reports and Fitbit data. And then there are linkages available to several external measures like census data, pollution maps, area deprivation indices, and more. It also includes data collection from parents on physical and mental health, substance use, culture and environment, and those external linkages. So there's a lot of really rich data here, as you can tell, particularly for those who are working in the mental health space. These are just a couple of example publications related to mental health using the ABCD dataset. There's hundreds to choose from, but I think these are the most widely cited. So hopefully that you can get a sense of how researchers are using these data. Many are looking at predictors of development or risk factors and looking to quantify the risk of certain exposures like substance use or screen time. There are also some really great papers out there that just provide more background on the study, its design and recruitment procedures, and how to use the data. So I can send these around as a follow-up, as I would really recommend checking them out. And I'll touch on data access procedures for just a moment because you do need to request access to the data by submitting a data access request and then receive a data use certificate. And so in order to do that, you must be affiliated with an NIH-recognized research institution. Your institution must also maintain an active federal-wide assurance within the Office of Human Protections, and U of M does meet both of those requirements. And finally, you must have a research-related need to access the data. So you'll be asked about your study plan and the goals of your research. Once access is granted, you'll receive access for a year, which can be renewed, and there's no cost for the data. However, and this is important, new requests for data are currently paused as the study moves to a new data infrastructure platform and adds some additional security measures. We understand that this is a temporary pause, and we're hopeful that data access will resume soon, but we still wanted to keep this session on the schedule today as we feel this is a really high-value option for when data access does resume. And then finally, before I turn it over to Dr. Voepel-Lewis, I wanted to offer just a brief reminder on responsible research practices, which is really relevant to working with all types of data, but you might have seen or heard about an article that was recently in the New York Times about a group of fringe researchers who improperly gained access to the ABC dataset to advance some conspiracy theories and work that was not in line with the values or goals of the study. I'm not going to say too much more about that article because unfortunately this is something that can happen with really any data set or type of data, but thought it would be a good opportunity for just a little refresher on responsible research practices. So first, be clear about what your intentions and goals are for your research and show scientific integrity, so meaning do what you say you're going to do. Protect participant safety and privacy. So luckily, in this case, data from the ABCD data set are always de-identified, but generally speaking, only access identifying data when absolutely necessary. and make sure you have proper privacy protections in place. Comply with legal and ethical safeguards, including working closely with the IRB. Follow best practices for data storage. Consider pre-registering your analysis, which is a practice our team tries to do whenever we can using Open Science Framework or OSF. It makes I believe there's other platforms as well, but that's the one that we like to use. But this makes your hypotheses and analysis plan public in advance of running your data analysis to avoid phishing expeditions. We can answer questions about that process separately if you're interested. And then finally, make sure any misuse, misconduct, or serious deviations from your research plan are reported. So there are more practices to put in place, but just wanted to offer that as a brief reminder to everyone, and I'm sure you're already familiar with that as well. But with that, I will pass it over to Dr. Voepel-Lewis to share more about her work. So Terri, please take it away.
Hi, everybody. Can you hear me? Good. Okay. So I'm going to briefly, as Megan mentioned, just talk about our use of the ABCD data to examine what was of interest to our team was the relationship of the youth or child's symptoms and their substance use initiation. Can I advance this? Megan, you didn't really tell me how to advance this.
Sorry, just say next slide and I'll
Okay.
move forward.
Okay, all righty, thanks. So I'm not going to go into this slide because Megan did a really nice job talking about what the ABCD data set holds, the promise that it holds, but I will mention briefly why we chose to use it. So my work in clinical nursing has always been related to pain and related symptoms and how that pain relates to the child's outcomes. And particularly, I was interested in pain persistency during childhood and adolescence and how that might contribute to their substance use behaviors as they grow into adolescence. So when we were introduced to the ABCD, we realized that this ongoing longitudinal study would provide a wealth of information for us and really had lots of the measures that we were interested in looking at. The other thing that we were interested in is a large community sample. So the one thing that I would say about this database is it holds data from youth that were enrolled across the nation from school sites, not clinical sites. So these are children that aren't necessarily with clinical diagnoses, but many of them do have, or a proportion of them do have clinical diagnoses that the parents describe. So that's why we thought it would be of interest and would meet our needs to study our hypotheses and our aims. Next slide. So my studies were funded by the National Institute on Drug Addiction, and our overall goal was to identify critical risk factors and interventional targets on the pathway from persistent or worsening comorbid physical, psychological, and somatic symptoms. And particularly, we were originally interested in pain and how that goes along with anxiety and depression, which from my work in the clinical setting always seemed to be co-occurring in children that particularly had chronic pain. We were also interested in that pathway to prescription drug misuse or PDM, as you'll see on the next slides, and their substance use, particularly their use of alcohol, tobacco, and marijuana, since those are the agents that they were using in the young population. Next slide. So what we were originally trying to test here was a self-medication theory. We understood from international and national literature that many teens report using prescription drugs inappropriately or over-the-counter agents to manage symptoms such as pain, sleep problems, and fatigue. So often they would get these medications from their medicine cabinet or from friends or family to self-treat symptoms. We know that adolescents and young adults often describe somatic and psychological symptoms as their primary motivators for the use or misuse of controlled substances. And other literature suggests that PDM, or prescription drug misuse, and substance use rates are much higher among adolescents and adults with somatic and psychological conditions such as chronic non-cancer pain, generalized anxiety, post-traumatic stress disorder, etc. Next slide. So our aims were, we had three overall aims. The first was to model co-occurring pain, psychological, and somatic symptom trajectories from pre-adolescence to early adolescence and determine the extent to which baseline symptoms interact with proximal ecosocial factors to predict a persistent or worsening symptom trajectory. And a lot of this, our hypotheses were based on Bronfenbrenner's ecologic systems theory, which, as you know, posits that an individual's development emerges from their effects or influences from the environmental systems, primarily when they're younger, the family, to other social influences. The second aim was to model the relationships between emerging symptom trajectories and their prescription drug misuse and substance use behaviors by the age of 15 to 16 years. And then finally, the aim that we're working on now, and I won't go into that, was to apply innovative simulation modeling to inform interventional targets with the highest potential to curtail drug use among the most vulnerable teens, or what we hypothesized would be those with high symptom trajectories. Next slide. So this is just an overall depiction of our conceptual model. As you can see here, our aim one was really to focus in on these symptom trajectories when they start in late childhood or at age 9 to 10, which is when the ABCD sample was recruited, and look at interpersonal and proximal environmental factors that contribute to those symptom trajectories. And then the aim two over here on the right side of this figure was to see how that symptom trajectory and ongoing symptoms related to substance use behavior. And then we hypothesized also that that substance use behavior would not only be impacted by their symptom trajectory, but also by factors in the environment. Next slide. So for aim one, we tested two hypotheses. The first was that we would be able to differentiate children with a persistent or worsening symptom trajectory from other trajectories by age 13 years. The second was that, so we believed that symptom, like chronic symptom trajectories start emerging in late childhood. That doesn't mean they're always going to stay there, but we believed that when they do, when those symptoms or high symptoms start emerging, that they can contribute to a worsening trajectory over time. The second hypothesis was that the interpersonal, the child's biology, as well as proximal environmental factors such as the family mental health, functioning, and behavior would account for a significant and meaning proportion of their trajectory experience. Next slide. So our first paper was describes our symptom trajectories, which we were able to differentiate using the data release 4.0, which included 3 years of baseline through 2 years of follow-up data in the participants. Our sample included 11,473 youths who completed 2 or more of the annual symptom assessments, which included these symptom measures here, and that allowed trajectory analysis for the first 3 years. As was mentioned earlier, the baseline data started to be collected in 2016, and the 3rd year follow-up was completed by 2022-ish, at least for this release of data. Our symptom measures came from the Child Behavior Checklist, which, if you don't know, is a widely used screener for child behavioral and mental and physical problems. And then we also included some symptoms from the Sleep Disturbance Scale for Children, which has 5 subscales, I believe, but we were only interested in the somnolence subscale. And we chose these particular symptoms, pain, anxiety, depression, and somnolence, because we know from the literature that from some of my previous work, as well as other chronic pain researchers, that anxiety, depression, and fatigue or daytime sleepiness often go along with pain as pain becomes persistent and worsens. We also included in this study pubertal stage, medical comorbidities, and youth-reported pain, which they started collecting in year 2, which is really just a very simple measure of pain intensity, which for our purposes really didn't mean a whole lot, except to say that the kids with the higher trajectories did report worse pain. Megan, can you, next slide, please? So for this aim, we split the sample into no pain, which was about 35% of the sample, the children that reported no pain to their parents at all during the 3 years. And that was like abdominal pain, headache pain, or general body aches and pains. And then a pain group, which was the remainder of the sample, who reported pain on at least one of the annual assessments. We used a person-centered multivariable trajectory modeling for applied to both strata, and we fit these groups based on their latent class growth analyses for repeated observations of these symptoms and how they went together. Our analysis yielded 9 trajectories, 4 in the no pain trajectories and 5 in the pain trajectories. But here I just described 5 of these. The no pain, no symptoms, which was about nearly 1,500 kids in the sample. And then you can see here these higher symptom groups, which had fewer kids, but still a significant number of kids. And for our purposes, we were really interested in these moderate pain and comorbid symptoms, as well as the high pain and high comorbid symptom groups. Next slide. Here's just a visual depiction of these groups. One thing that I do want to point out that overall symptoms that were reported in these subscales were fairly low. I didn't provide here the range of possible scores, but just here looking at figure C, the high pain and high symptom group, you can see here that anxiety was one of the higher symptoms reported, but pain was only measured on a 0 to 6 scale, but it was still much higher than in the other trajectory groups. And what's of interest here, and this held true and continues to hold true in our more recent releases, is that the symptoms of anxiety seem to be curtailed or lessen over time, while symptoms of depression, this blue dot on this figure, seems to worsen over time. Somnolence appears to stay the same, but if you look at the raw numbers, they actually did worsen over time and into adolescence as we moved into years 4 and 5 of the follow-up. But you can see just visually, this high symptom group was significantly higher in all symptoms overall. Next slide. And this was by year 2 of follow-up when the kids were about just under age 13. So they were, I think their average age for that study at the end was like 12.8 or something like around that. I don't have the exact number. So what we found in this study too, for just a general characteristics of the high symptom groups, was that even though the overall average of scores within those groups seemed to be fairly low, the T-score cut points, which are available data in the ABCD, were particularly high among the moderate and high symptom groups. They were ranged from 44 to 82% of those groups had at-risk or clinical level anxiety and depression versus 0 among the asymptomatic group. These kids in the higher groups had higher medical comorbidity, not surprising. They were more likely to be female, white, and non-Hispanic compared to the asymptomatic groups or the lower symptom groups. The highest symptom groups had a higher likelihood of non-routine medical and mental health care visit. In fact, the highest comorbid group were 26 times as likely to have reported at least one mental health care visit during the 3-year period. I will say that the measures of healthcare utilization are pretty simple, but at least you get an idea of what their healthcare utilization was like with these sort of simple measures. There were some differences by race, ethnicity, and household income, and those are reported in the paper. Next slide. Our second hypothesis of AIM-1 really looked at the effect of the child's proximal family on these symptom trajectories. So the paper was published just recently in Social Science and Medicine um, by our grad student, Thea Sanger Carpenter. She was our PhD student at the time. We used for this study data release 5, which included the baseline as well as 3 to 4 years of follow-up data. So we're able to add a couple of years of data. So we reran our trajectory analysis for this study. And for this paper, we were only interested in the kids who reported pain at least once in those across years. And so our sample is 7,500 use, and we excluded use with missing symptom data for 2 or more years so that we could get an accurate trajectory. Megan? This is a depiction of what we were testing in this model, and we were looking really at family adversity measures, and we wanted to assess how earlier childhood experiences differed from more recent or proximal experiences or exposures. And we list here the measures that we included in this. And what we were looking at is trauma exposure, which were measured with the KSADS, which most of you should be familiar with, which measures many mental health um, symptoms and diagnoses. We also measured here parental mental health problems, which was assessed by parental report on their family medical history, as well as the adult self-report measure and the adult behavior checklist measure in more proximal years. We looked at parental substance use problems. And by the way, the reason that we use that term problems is because that's the terminology that the ABCD used. We've been told that we don't like that terminology, a problem, but parents were asked whether or not they were seen by a medical provider or a counselor for a mental health problem. And so we use that same terminology here. We also looked at somatic problems using those same surveys. And by the way, we used T-score cut point for most of these things, except for substance use. And then we looked at financial hardship, which was measured by parental self-report on 7 items that assessed whether or not during the year they had trouble paying for things like medical, dental visits, food, um, rent, and other commonly used services. Family conflict was measured by youth report on a well-documented survey. And then finally, we looked at the youth's report of how supportive and caring their parents were. Again, as I mentioned, we measured these up through baseline, which was measured at baseline by asking the parents or child how often ever they had these things. And then the proximal adversities were measured at year 2, which was right in the middle of this data collection period. And then the outcome here was the symptom trajectory. Next slide. So controlled for demographics and some of those other factors that predicted our the trajectories in our previous paper, as well as physical injuries, both baseline and interim physical injuries. We were able to show that the high pain, high symptom trajectory was associated with both early and proximal or recent exposures to trauma, parental mental health, and somatic symptom problems. We also found that the proximal exposures to financial hardship and family conflict contributed to the trajectory, whereas the earlier exposures did not. And then really interestingly, higher supportive caregiving, both early and proximal, reduced the likelihood of the highest symptom trajectories. Next slide. So moving on to AIM-2, we wanted to examine the effect of the symptom trajectory with substance use and among youth in the ABCD study. And then we wanted to also test what was the impact of social environmental factors on substance use, particularly for those with comorbid psychologic and somatic symptom trajectories. Next slide. So again, this is just referring back to our conceptual model. This is the AIM2 factors that we were looking at. One of the things I just want to mention, the items in the gray boxes were both the child and the environmental factors we were looking at. We looked at risk perceptions. Medication we did not really look at, and I'll explain why we didn't look at the influence of medication, primarily because we weren't able to look at prescription drug misuse. But we were able to look at family factors such as their behaviors, their monitoring, their rules, as well as peer perceptions, the child's perception of peer norms and their behaviors. Next slide. For this, we used the 5.1 data release. We included youths with at least 4 years of complete symptom assessments, and for paper 1, who also completed either the 42 or 48-month substance use survey. Just as a side, substance use is reported every 6 months by the child. So we collapsed those data into annual assessments by combining the mid-year and the annual assessments. We excluded those who reported any substance use at baseline. There were only about 50 or 60 kids who reported more than a sip of alcohol or a full tobacco cigarette or any marijuana product. There were only about 50 or 60 of those. We excluded those for both of these studies. So as I mentioned, the substance use, there's a really good paper by Barch and Lindahl, I believe, that describes the substance use measures. For those of you interested in this, I can send you a biography or a bibliography. But they describe the gating and timeline follow back items. They elicit substance use behavior for all major drug categories, and they have added some categories over time as other things come into the view of substance use researchers. Because there were few cases of prescription drug misuse, we really couldn't examine this outcome, unfortunately, as of this data release. There was pretty low usage by age 14, so primarily we focused on alcohol, tobacco, and marijuana use. The other thing is that sort of those particular agents track their measurements of substance use expectancies, which is the child's or the youth's attitudes about these drugs, whether or not they have positive or negative beliefs about what would happen if they used these items. We included measures of substance use problems, as we mentioned earlier. And then for paper 2, which was those other environmental impact or factors, we included measures of the youth's substance use risk perceptions, parental monitoring, parental substance use rules about the child using substances in the household or outside of the household, and then peer disapproval and peer substance use. Next slide. We reran the trajectory analysis because we updated our database, but we also ran this on all youth. We did not split the sample into pain and no pain because we couldn't look at prescription drug misuse. And so we didn't believe that it was important to split these kids out. The best fit included 4 trajectories. We had almost a completely asymptomatic group, which, as you can see, was more than a quarter of the sample. There was a low stable symptom group, 39%, and then there were fewer kids in the moderate persistent group as well as the high worsening group. When we looked at the characteristics of these children, we saw that their characteristics pretty much tracked the earlier trajectories, so that the high worsening group had a much higher rate of having clinical level depression and anxiety. The rates of early onset substance use by the end of the study here, that was about 8th grade, which these kids were about age 14 by the end of the study. Any use was almost 10%, 1 in 10. Alcohol use and tobacco use were the higher agents used. You can see here 3.8%, and tobacco was about 5%. Marijuana use was used only by 3% of the sample by that time. And there was a smattering of other agents reported, which you can check our paper out for all those numbers. Next slide. We did find again, in our addictive behaviors paper, we really focused on the association of the symptom group and outcome. And we did find that the moderate persistent group and the high worsening trajectory groups were at higher risk for substance use compared to the asymptomatic group. And you can see there their adjusted odds ratio was 1.8 and over 2, respectively. Parental substance use problem increased the risk for substance use more than 2 times, and then higher positive expectancies increased the risk for each of these agents. Importantly, and you guys would be interested in this, that we did some time-lagged mixed effect regression to see which of the symptoms mostly predicted substance use and whether or not substance use contributed to worsening symptoms thereafter. And we did find an effect of depression on subsequent substance use and an effect of substance use on subsequent depression. Anxiety, however, was not related and both of these symptom scores were included in the same models. Next slide. In our second paper, which looked at the additional impact of the environmental factors, we did sequential modeling to look at child in the first model. Then we added family to the second model and peer factors to the third model. And we found that in the first model, there was an effect of symptom trajectory and risk and the child's risk perceptions on substance use. You can see here that the higher the risk perceptions actually lowered substance use, whereas higher symptoms increased the risk of substance use. The effect of the family at step 2 showed that indeed parental substance use, permissive rules compared to no rules, permissive rules compared to restrictive rules, as well as parental monitoring were associated with substance use. The higher the parent monitoring reduced substance use risk. And then finally, when we added the child's perceptions of their peer disapproval as well as peer use, you can see that there was an effect of both of these where, and peer use, because peer use was very low, we had to collapse this as no peer use versus one or more of close friends used any of these agents. And you can see that peer use really increased the child's own risk of substance use. The parent factors remained significant in that final model, but the effect of the symptom trajectory became non-significant. Next slide. So overall, most of our hypotheses were supported. We weren't able to test all the things we wanted to. We were unable to comment on the self-medication motivation because while they do collect motivation data for those kids who report use of alcohol, tobacco, or marijuana, it was very sparsely reported through release 5.1. We were unable to examine the effect of symptom trajectory on PDM. Which because there was very little reported. And then, but we do believe as substance use initiation expands into the older age groups, there will be more opportunities to examine substance use and substance use disorder in detail going forward. Next slide. So some of the things that we found that were strengths in the ABCD, the sample is really diverse, but it is somewhat well off, and the socioeconomics or the household income typically tends to be higher than the average in the country. There are many valid and reliable measures available in the database, and there are these more recent links to community indices, which are really helpful. The assessments cross into all spheres of the biosocioenvironmental influences on youth development, which is really exciting for our work. And the annual assessments really allow an examination of trends, who gets better, who gets worse over time. I've always done prospective data collection in the past, and I would probably gather some of this information a little bit differently, but because it's such a huge national database, it certainly can't have the detail that you would do in a simple prospective analysis. The pain measures, therefore, in the database are not very robust. They do have some self-reporting, but the self-report measures are, they only ask the child about their past month pain, and so they really don't match or tie into what we would describe in the clinical community as chronic pain measures. The prescription medications are string data. They require a lot of review and coding, which we did through year one of follow or through year two of follow-up. So we have 3 years of prescription medications coded, but it was a lot of work. And so going forward, it would be nice if somebody at a national level did that for and then tied those data to the ABCD. The releases are really delayed, but they do detail their new releases with fixes, especially for coding, et cetera. We found the data dictionary navigation to become cumbersome over time. Initially, we were able to download spreadsheets, Excel spreadsheets that we did fortunately before they switched their system. And so we have spreadsheets on most of the measures that we were interested in, but to find them now is a little bit, I think is a little cumbersome, although it may be because I haven't explored the database that well in the last couple of years because we've downloaded it a couple of years ago. Is that all I had, Megan? I think that was it.
Yeah, that was great. Thank you so much. Really appreciate you sharing more about your work and your experience. We have a couple more slides before I wrap up, and then we can turn it over to questions. If you have questions, you can start putting them in the chat now, chat or the Q&A. But first, I'm wondering, Sarah, did you have anything to add about this data set? I know you've worked on a couple of papers here with Terri too.
I can't tell if I'm on. There I am.
Yeah, we can see
Sorry,
you.
I don't know that I have anything. Terry did such a nice job talking about kind of our experience and work that we've done. I think you see Terry talked quite a bit about our work more, although it is, she also talked about some of the mental health measures and related measures, but, a lot of what we have done so far is a little bit more substance use focused. But I think it is just such a wealth of information. And I know both of us, I think, are excited about watching and waiting for the data as the kids get older too, and the participants get into kind of, more later adolescence. So I don't know that I have anything more to add. Thanks so much, Terry.
Great. Well, I just want to point folks to a couple more resources before we wrap up and turn to questions. First, we do have 2 more upcoming sessions as part of this series. Next month on March 11th, we'll be featuring the Health and Retirement Study, or HRS, which is housed here at University of Michigan and is a landmark study of the health and well-being of older adults. That session will feature Dr. Grace Nopert, Research Assistant Professor at the Survey Research Center at ISR, and she'll share an example of her work that is looking at immune aging. And then on Wednesday, April 8th, we'll be featuring the National Health and Nutrition Examination Survey, or NHANES, which is a nationally representative cross-sectional survey that collects information about the health and nutrition of U.S. adults and children. And that'll feature Dr. Sung Kyun Park, Professor of Epidemiology. And so we hope that you'll join us at both of those. You do need to sign up for each session separately, and I will send the link to register around again with our follow-up message. There are a few different ways that you can get more support from our team if you're working with secondary data. The first would be to apply to be part of our research incubator program. This program offers hands-on support from our team for secondary data projects that are relevant to mental health that are led by early career scholars, so pre-tenure faculty and postdoctoral trainees. It's a really fantastic way to get more support and experience working with secondary data and to get projects completed if you have limited funding or protected time for research or you don't have a research team. It's a very unique program compared to other offerings across campus in which you get the support of our research team at no cost to you. Applications will open up in the spring, and we usually host an information session if you'd like to learn more. If you are on this call right now and you would be eligible to participate in the program, I will send you that information when it's available. We also offer a range of written resources that you can review on your own time, including a dataset library where you can review different secondary data options for mental health research. We have tutorials and coding examples on GitHub. And you can also request a one-on-one consultation with our team if you're looking for data or need help with your analysis or just don't know where to get started. We're always happy to help, and that is available at no cost. And you can request that on our website, which I will also send around. And I'm sure you're all familiar, but there's many more resources available to support your secondary data work available to the U of M community outside of the Depression Center. A couple I want to point to specifically. The first is ICPSR, which is a massive hub for pre-existing data sets and really a global leader in archiving data. They also offer many trainings and resources, such as their Summer Institute in Quantitative Methods. So they're an excellent place to go if you're looking for data or looking for more training or have your own data that you are interested in archiving. U of M's Data Office for Clinical and Translational Research oversees the self-service data tools like Data Direct, which provides access to the University of Michigan's MyChart data record, and also eMERSE, which gives research access to clinicians' notes. So they would be the place to go if you're looking for access to either of those tools. And then finally, the Institute for Health Policy and Innovation, IHPI, their Data and Methods Hub offers many policy-related data resources and analytic assistance and are a really fantastic resource. And so with that, that is our last slide, and we can open it up for questions. I see a couple have come in. Again, if you have more questions, please put them in the chat or the Q&A. So this is a question for Terri. Hopefully, I see you're typing, but hopefully you can also answer out loud. But it says, the JAMA article that you shared seems to discuss some healthcare utilization measures. Can you say more about what kinds of healthcare utilization measures are in the ABCD study?
Yeah, can you hear me?
Yes, we can hear you.
Okay. So yeah, these are, as I mentioned, they're really very simple measures. So first of all, each year the parents are asked during the past year, has your child, and this is verbatim, and I've described this in the paper. During the past year, has your child seen a doctor, a nurse, a dentist, or any other health professional other than for regular checkups? So we called it non-routine health care. There was another question, has he or she been to an emergency room in the past year? And so we combined those two to say that they had a non-routine healthcare visit. And then the DSM-5, I think it was the KSADS diagnostic survey, asked whether or not the child had received mental health or substance use services in the past year. And that was our measure of mental health care. So unfortunately, as a clinician, it was very difficult to discern why they saw somebody. There are some questions about, has your child had an injury? So you can sort of get an idea of whether or not the child has injuries. We know whether or not they have comorbidities, but we don't know why they saw a healthcare provider. So really, these are really cursory measures of healthcare utilization. So that's why we've done another study. We published another off-AIMS study on healthcare utilization, but again, we don't know why they're seeing someone. Someone else asked about publications. The ABCD website, if you go to that, they list a lot of the publications. And anyone who uses the data are supposed to report their publications. And so every year when I update my data use contract, I report what publications I've had in the past year.
Great. There's also a question from Ty. It says, is it possible to recruit participants for qualitative interviews from the ABCD data? I don't believe there's qualitative data in the data.
And they will not release any names to anyone. They won't release names or locations to anyone. So they do have geocoded data, but only the primary investigators, the main investigators, utilize that data, and they link the data to other national databases. You can't even do it. So they won't release any of that information. They do have, by the way, I know that There's a new data release. I think it's 6.0 or 6.1. But because of the administrative changes and priorities, I don't know if they're scrubbing the data or if because there's a lot of stuff in the data based on gender identity and other things like discrimination indices. And I have no idea if they're going to remove data or just not collect the data going forward to align with priorities.
Great, thank you. There's been a couple questions about whether this is being recorded and whether we'll share the slides. So yes, this is being recorded and we will share the slides. We will send this recording out to everyone who was registered for the session, and it will also be posted to our YouTube channel. So if you have colleagues who are interested in this topic and weren't able to make it today, they can still watch the recording later. So feel free to send it around to anyone who might be interested. We still have a couple moments left if anyone has any additional questions. We'll give it another minute or two. Okay, it doesn't look like there's any other questions coming in, but if you do have other questions that come up, you can be in touch with us over email. I just want to say thank you so much to Dr. Voepel-Lewis for her great presentation today and for joining us. Thank you to all the participants who joined us today. Thank you for being here, and we hope to see you at our next session next month. Have a great afternoon. Thank you, everyone.